Today we'll see this modification of the microscope setting in which you can manage a case who has photophobia. So this is the patient who had some amount of significant cataract, especially posterior subcapsular cataract, which was causing some botheration and needed removal. This is the fundus photograph, which is unremarkable. However, the other eye had undergone a keratoprosthesis implantation few years back, and to be exact about 4 years back, which has resulted into finally the loss of vision in this eye. And we can see this keratoprosthesis was still in place and this eye was symptomless. So apart from that, this patient had intense amount of photophobia and blepharospasm, which you can see the moment the corneal surface is irrigated, the patient has nearly total occlusion of the palpebral aperture. So I decided to operate this patient under very low light. Now because this was nearly a posterior subcapsular cataract, so there was good retroillumination glow present. So I increased the retroillumination setting of the microscope and dimmed the oblique illumination. So nearly whole of the surgery was done under this retroillumination only. Some supplementation of the topical anesthetic jelly just to make the patient a little comfortable, but still, as we can see, patient has significant amount of guarding reflex. So we have made the corneal incision and we are proceeding to inject intracameral lignocaine, which will make the rest of the procedure painless. So patient has been urged to look at the light, which is very dim now, and patient is able to cooperate well, and we'll proceed for phacoemulsification. So the first step is to do a capsulorhexis, for which viscoelastic gel is injected into the anterior chamber, and now we are proceeding to make a capsulorhexis. I'll request the viewers to view this rhexis process very carefully, and we can learn a tip here. Now at this moment we can see the rhexis is proceeding, but here we can see just now that the rhexis was proceeding to go peripheral. So this was recognized well in time, and this means that the chamber is getting shallow and this needs viscoelastic supplementation, which was done. The rhexis is restarted and we'll see the chamber is again getting shallow and the rhexis is running out, and if one can identify these events timely, it can be manipulated by deepening the chamber repeatedly and then proceeding for the remaining part of the rhexis, as has been done here. So although the rhexis is a little eccentric, but still it is intact and complete. So now proceeding on to phacoemulsification process. Before that we will make a side port and do a hydrodissection. In these kind of cases I always like to do a hydrodelineation, which defines the size of the nucleus and also separates the epinucleus, which makes the surgery and manipulation of the nucleus easier. So hydrodissection followed by hydrodelineation, which will define the nucleus in form of this golden ring. So we can see it's a grade 2 nucleus, not very large, not very hard. So we'll proceed for phacoemulsification now. Removing the overlying cortex so as to bare the nucleus, and we can see the bevel is down. So the chopping maneuver can be done with bevel up or bevel down, and it has been proved by few studies that chopping, the primary chop, is more effective if the bevel is down. So it's a choice. Bisecting the nucleus into 2, into 3, and then removing the pieces as they come to the phaco tip. So it's a soft nucleus. These kind of nucleus, which are small and soft, can usually get prolapsed into the anterior chamber, but because they are not too bulky and the phaco power required is too less, so there is usually no threat to the endothelium. Removing the epinucleus just like that by aspirating it, pulling it out of the bag, and it comes into your phaco tip very easily. very minimal amount of phaco power is used for removing these kind of soft cataracts, so there's nearly no collateral damage. We can appreciate the illumination is still kept low, and we are working nearly under retroillumination only. So the retroillumination here is providing good amount of clarity and view, and patient is also not bothered by the intensity of the light, being a slightly more apprehensive kind of patient. So this is one solution for these kind of patients who have too much of reflex blepharospasm and they are having difficulty to fix on the bright light of the microscope. The view is very clear because the retroillumination provides very good view and very discerning view of the refractile fibers of the lens, especially in immature cataracts. Injecting the viscoelastic and also using it to polish the posterior capsule so as to remove remaining sticking tidbits of the lens fibers. So this is a preloaded IOL from Aurolab, which is a negative aspheric lens, and it also provides some amount of extended depth of focus, which is very useful if the patient is opting for a monofocal lens, and I've seen patients getting good vision and even up to 6x6 unaided and N6 because of the negative asphericity. So the IOL has been implanted and we can appreciate the glow, and this surgery has been done under minimal of oblique illumination and just the retroillumination was used, which is relatively a dim light, but because it is reflected from the retinal surface, it provides a very good view and contrast of the refractile media, the lens fibers, the capsule, each one of the structure which is handled here in an immature cataract. So the viscoelastic is removed, and now it is the time to form the anterior chamber and seal the anterior chamber. This is the day 1 post-op picture where you can appreciate the pupil is dilated, the IOL is well centered, and most importantly the cornea is absolutely clear. Thank you.